don't believe I have an order question, so don't stress yourself about it. Okay, so in order to hydrate a patient with HHS, since we decided this is HHS, we're going to rehydrate the patient. So here is my concern with this patient. This patient has an osmotic diuresis, which may cause the patient to lose 100 to 200 milligrams per kilogram of fluid. So that's quite a bit of fluid. They tend to lose even more fluid than the DKA. So, can someone tell me how I'm going to rehydrate this patient from the notes that you have?
Hypotonic solution.
Okay, let's see. This is somebody with hemovolemia. What did we come out with? 339?
Yes.
So we probably would want what type of fluid?
The hypertonic fluid.
I would want the hypertonic, but according to your book, if you notice there's a calculation on the sodium. If you look in the book, with HHS, it's dependent on the physician or the nurse practitioner or whoever, if they're gonna use half normal saline. In HHS, they may use half normal saline if the sodium is up a little bit. Okay. In this patient's case, the sodium is really normal. It's like a high normal. So okay. So normal saline, half normal saline, I can accept that because that is what the textbook and all say. About how many in what time frame would you give that first liter? Does anyone know?
Probably
30,
within
30 minutes?
First hour.
The first hour, within that first hour. Very good. And how many more liters they want within a 24-hour period?
Eight.
probably up to
Eight.
4.
Oh.
8. The DKA, I think, is up to 4. The HHS is 8. Okay, you all did good with that. All right. Support your hemodynamic DKA and HHS. So, what are we going to monitor with this patient?
I'm sorry, I didn't catch the time frame on the 8 liters. You said within the first hour is the first liter, and then within that, how many hours is the next 8?
Given in 24 hours.
24 hours. Okay.
Yes, ma'am. All right. So, pretty much some of you hadn't been in ICU yet, but you're going to monitor. You're going to monitor the vital signs. You're going to put them on a cardiac monitor. You're going to monitor the blood pressure and your heart rate. With this patient being in a fluid volume overload, what type of shock do you think this patient could have?
Cardiogenic.
Very good. This patient is likely to be into cardiogenic shock. All right? So you want to monitor the fluid. This particular patient can actually have a myocardial infarction. Okay, let's look at the control of the hyperglycemia. Did anyone find the notes on that? Because it was, you could look in the book, but I actually spelled it out in the lecture. So I heard someone, I think it was V. I can't pronounce your whole name. I'm sorry, sir. But I remember him talking about the regular insulin. I heard somebody say regular insulin. So
Yeah,
that's the way we're going to control it, right?
Yes.
So you're going to give a bolus of regular insulin. Does anyone know how much for the bolus? Okay, you usually initiate by 0.1 unit per kilogram. So that's going to be your bolus. I'm not sure if it's written on your outline or not. It may not be.
John, is that a bolus both for DKA and HHS?
Yes, right now I'm talking about support, glycemic control. So they are separate, and I'm going to get to the part that separates it. When it becomes separated, it's usually with the fluid. The fluids are different. Um, and I also have what you would do with HHS later on. All right. So you're going to use an IV pump and you're going to titrate. All right. Does anyone know how fast to titrate? The settings to titrate it.
Is it 50 to 70 milliliters an hour?
There's a 50 to 7 milligrams per deciliter per hour, and that's a decrease. You decrease it like that, but your titration is done by 0.05 to 0.1 units per kg per hour. You don't want to drop it too fast. And I'll tell you what that other number, because somebody got it, but it's the glucose decreasing. You don't want to do the glucose to decrease too fast. So how you're going to titrate your insulin is 0.05 to 0.1 unit per kilogram per hour. Now you never want your glucose to drop. But you don't want it to drop too fast, meaning you don't want it 80, because if it's 80, you might bottom your patient out. You want your increments of 50 to 70 milligrams per deciliter per hour. So if you see your glucose dropping quicker than that, you have to back up off your insulin. All right? So you want to decrease your glucose by 50 to 70 milligrams per deciliter per hour. And when you get a chance to go back and listen, it'll be in your in the lecture as well. Now this is where I'm going to say for HHS. If the glucose for HHS is less than 300 milligrams per deciliter, then you're going to decrease your insulin by 50%. So if your glucose for HHS is less than 300 milligrams per deciliter, then you're going to decrease your insulin by 50%.
Are we decreasing the rate or the dose?
You're decreasing the dose, which is going to decrease the rate as well.
And are you saying 50 or 15?
50%. 50.
Thank you.
All right. Now, your target glucose is 140 to 180 milligrams per deciliter. That's the target that you're going to try to get to.
Is that for HHNS or both of them?
Just HHS.
Okay.
I'm keeping most things about HHS because that's what this was. When you get to your actual lecture, you'll see the difference between the DKA and the HHS. If I have time after, if you need me to highlight it, I'll highlight it. Okay. Now, different facilities have different protocols. So, once the glucose, for testing purposes, once the glucose is 200, then what you're going to do, is you're going to decrease your insulin according to the protocol. So whatever protocol you have at your facility, more than likely when it gets to 200, they're going to decrease the insulin. And the reason I don't go into details with protocols is because different facilities have different protocols. Everybody doesn't have the same. And even inside the facility, if it's hyperglycemia, they don't use the DKA algorithm. They don't use the HHS algorithm. They use one particular one for hyperglycemia. So it just depends on what's the disease process. It will be what algorithm they will use. All right. I think this is where Mark was going earlier. I don't know if most of you heard him, because you might have been on break. But anyway, now we're going to try to monitor the electrolytes. So this patient will probably have issues with hypokalemia, because they're diluted. Everything is diluted. So we always want to make sure that we know what our potassium is. All right? So remember when you were taught before, I believe you were taught, you all might have had Mr. Darling, and you all might have had someone else, I'm not sure, but he just left, so you all probably did have him. But if in fact you have an issue with potassium, if your potassium is low, what do you think you want to do?
You need to be on a cardiac monitor.
Then
You hold back on the insulin.
You hold back on the insulin?
No, you can request a K rider.
Yes, you can request a K rider, but if it's extremely low, you don't want to give that insulin. Can someone tell me why?
Because the insulin shoots the potassium back in the cell, making the serum potassium low.
Very good. All right. So just keep that in mind. It'll make it even lower in the blood level. And especially like once you rehydrate the patient, because this patient is diuresis, because of osmotic diuresis. This patient, once you get the volume up or whatever, the potassium is going to start pretty much floating back in the cells as well. So just be careful, because this patient is prone to cardiac arrest because of the hypokalemia, sorry. All right. Now, let's go to the last part of it. What are some of the things you would think would have caused this hyperglycemia?
The infection.
Infection. The patient does have a temperature. Yes, 101.4. Elevated heart rate. So, and the WBCs is like 15,000. I should have wrote my norm down. What's a normal?
5 to 10.
Right.
1,000.
Okay.
So, possible sepsis. And
Well,
also,
go ahead.
I was going to say possible perfusion is lacking right now because the MAP is 66.
Right.
So, definitely some cardio issues going on, septic issues that's going on. Okay. Now I have a question about the insulin drip. But since
go ahead.
The potassium has we have to monitor the potassium for sure because of the insulin's now involved. So is there a way, how can we, I guess, bring the drip to its lowest at, well, not say bring it to its lowest, but like, I guess decrease the drip factor, if that makes sense, for as insulin, for as a regular insulin.
Okay. Yeah, there is an algorithm that you would have to follow. And that's what I was talking about. Different facilities have different protocols. A lot of times, if I have not initiated the insulin yet, and I have done the fluid resuscitation, I would make sure to do like Mark had suggested, is to get some K riders in that patient before you give that insulin, because you're already low, and if you give the insulin, you put if the potassium's already low and you give that insulin and shift it into the cell, then yes, the patient could have a cardiac arrest. So it's according to your algorithm, but if I haven't initiated my insulin, I think I would kind of initiate it after I get a potassium. Did that answer your question, Ms. Rome? Thank you. All right.
Thank you.
Thanks. So, we said infection, yeah. It's
But
definitely.
if their glucose wasn't controlled good enough, would that have made them more susceptible for that infection in the first place and kind of just snowball affected from there?
Exactly. The infection is probably what elevated the glucose. The patient might have been taking their medication properly, but certain stressors and especially infection would cause an increase in many of your patients' blood glucose. So yes, you're absolutely right. It kind of snowballed. Very good. All right. Let me see if I have anything that you all didn't say. Do you all remember anything about sick days for diabetics?
Sick care management or something like that?
Yeah, like, okay, because you know how sometimes patients, they'll be at home, but they'll have sick days?
Is it like they have to keep taking their insulin even when they're sick? Wasn't that what we learned?
Okay, what they're saying is that the patient should continue their insulin during the illness. Sometimes the insulin is required, but they need to monitor their sugar, right? I'm not going to ask you about, well, I can't say I'm not going to ask you about the frequency, but they need to do it more frequently. So if this person is not eating, they should remember to monitor their glucose like every 2 to 4 hours. Okay? So when they're sick, and particularly if they're not eating and they're just drinking like broths and different things like that. Now, this patient is a HHS. So what's the difference between the HHS and the DKA when it comes to ketones? If you compare it like that.
The size of the ketones?
The amount of ketones, correct. Because the HHS, sorry, telemarketers, that's all it is. The HHS have very little to no ketones because this is not an acidotic problem most of the time. So they're not going to have ketones. But let's say if we were talking about a DKA patient that's a diabetic type 1, with the sick care, what tests can they do to see if their ketones are elevated?
A urine test, huh?
For yes, a urine test. And what urine test was that?
A urine test for ketones?
Exactly. So they do a dipstick. And of course, if it's large, they probably need to bring themselves to the hospital. Okay? So what would you tell a patient that's not eating?
tell them to continue to monitor glucose.
They monitor the glucose. What can they take? They can drink fluids, right?
Sip throughout the day.
Like broth, clear liquids, different things like that. But caffeine, you tell them when you do your patient teaching, no caffeine. Oh, thank God I don't have that issue. I need my caffeine. So anyway, when they're having problems, they need to get in contact with the healthcare provider. All right, that's one thing I want to make sure that you're all aware of, is to tell them when you teach them that they need to, whenever they're ill, take their insulin, but only according to the blood sugars. And if the blood sugar is dropping, they don't want to just take insulin. You know, they need to probably come into the hospital. All right? So, let's see. Enough of that one. Do you all have any questions with that? All right. All right. My computer feels like it's overworked. Okay, there we go. This one is going to be brief. We're not going to break up into groups. If the pictures of your colleagues are in a way you can, like, hold the, I guess the left side of the mouse down and bring the pictures down lower. Let me see if I can increase. Let's see. Oops, didn't want to go there. It's overly sensitive. All right, I think this is the one I want to be on. Good, you already seen the answers. Let's try that again. All right, from here. And let's do. And my computer don't want to cooperate. Well, anyway,
if you want the slideshow, click from current slide.
Thanks. All right. So here is a person that enters the ED. Now this has to do with diabetes insipidus and SIADH. So this person, I think I told you what his problem is. So he fell off a ladder about several days ago, and he lost consciousness. Now, if you got a chance to review the lecture, what you will see, if they put out copious amount of urine, and they drinking nonstop. All right, so he's always thirsty. So you see what he has. He has a small intracerebral hemorrhage. And he was admitted to the intensive care unit. Let me see, I got to move these pictures. Let's try this. All right, let me just shrink it. There we go. So you see where I said that the patient is diagnosed with head trauma and diabetes insipidus. Well, you all had your lecture yesterday in regards to TBI. So when you look at this, what are the physical findings that you will see that would determine that this patient has DI?
Well, he hit his head, so like the pituitary gland is in the brain, so it could have been damaged.
Very good. Yes.
And he's peeing a lot.
And he's urinating a lot. Very good.
He's very thirsty.
He's very thirsty. Okay. All right. So what problems that you can see in this patient that may occur?
A fluid and electrolyte imbalance, dehydration.
Fluid and electrolyte imbalance, dehydration. Very good. All right. Let's see. Identify the nurse's measure that would assist the patient to maintain adequate fluid balance. Does anybody know that answer?
Let them drink water.
Exactly. Because these people are usually hypertonic. You know, they're at a fluid volume deficit. So if they can drink, let them drink water. You're going to have to do something that's called fluid replacement in these patients, okay? And what they usually do, because the patient can put out anywhere between 4 to 30 liters per 24 hours, you know you got a fluid volume deficit. When you see those patients' urine, sometimes it's extremely clear. You know, they would actually have a specific gravity almost equal to water. They would have a specific gravity of like 1.005. So you definitely want to replace any fluids that they remove, and you can replace it with free water or half normal saline because they're hemoconcentrated, and because they're hemoconcentrated, you wouldn't want to give them any extra solutes, so you would want half normal saline. D5W I don't talk about so much, but D5W is a hypertonic solution once it enters the body. It's not necessarily hypotonic when it's on the shelf. So, and the reason I don't talk much about it is because if you give somebody copious amount of D5W, you're going to have to do anti-checks. All right? So, you're going to do fluid replacement. All right, well, you got the healthcare provider gives 10 units, IM every 3 to 4 hours as necessary. Okay. I think your next thing is going to be working this out. Let me see if we got time. I'm just going to let you all have the answers for this one. I have 3,000. Okay, that's the difference. When I worked it out, this is what I got. Now, there's a difference in 3,000. What does that mean to you?
It means they're getting too much or putting out too much.
Okay, so let's look at it right quick. Your intake was 8550. Your output is 5550. So, according to that, it looks like that patient is what? Holding on to fluid? Since they still got like a net of 3,000. So this patient would probably be considered what fluid status?
Overload.
Overload.
Yes, good, overload. Very good. All right, this is the same patient. you're talking about SIADH, this is a fluid volume overload. DI, which is diabetes insipidus, is a fluid volume what?
Deficit.
Right. So think of SIADH as a fluid volume overload. And sometimes when you give a patient vasopressin or desmopressin, they can shift from one to the other because SIADH can be a side effect of the desmopressin. So we just have to be aware of some of the signs and symptoms of the medication. Now, this patient is fluid volume excess. So some of the things that we're going to do for this patient is not give them so much fluid. We're going to have what they call fluid restriction, especially the free water. All right? So this patient, yes, I didn't answer the question on the other one, but most definitely it is life-threatening, and it's life-threatening in the fact that your fluid volume overload can mess up your electrolytes. You can send your patient into a cardiac distress. So there are a number of things that can happen. Just from back when you first started, how many kilograms is equal to a liter of fluid?
1.
That one's easy. 1? Yeah. It's 1 kilogram to 1 liter of fluid. All right, that's very important to know. Now, this patient is going to have 3% saline. What are some of the safety concerns when infusing 3% saline?
Aren't we watching sodium?
Most definitely. They would check their sodium every 6 hours. Okay?
Headaches, seizures.
Yes. You want to make sure the sodium does not get too high because the patient can have, because I think this one was 120. The patient can have a seizure at 120, and it also can have a seizure if it's very high. So we definitely have to keep a balance with our sodium with this patient. This 3% can be very deadly. I've never seen it. I haven't been in step-down area. I haven't been in step-down areas for a long time. I don't know if they do it in the step-down area, but I know it's done in ICU. And they usually run it about 30 milliliters an hour. I have seen it a little higher, but usually when they run it a little higher, they're increasing the sodium too quickly, and you're not supposed to do that. You need to avoid that, or you can have major complications. Okay, so we're going to have, let's see, I think the other thing I want to share is a few test questions. You'll probably finish a little early because I didn't get you all to do those calculations for the INO. I know you all would be happy that I didn't, because the numbers, and you got to deal with the numbers, but you may see that somewhere, because I recall seeing it on somebody's paper when they were doing one of those standardized tests. So, all right, so I want these questions. All right, and slideshow, and all right, so here's the first question. What would you all say to answer?
A, B, C.
I put padding on the side rails. And
This
then
is a select all that applies, so just
I'm saying A and B.
A, B, and E.
A, B, and C.
Yeah, A, B, C.
A, B, and C. Okay. All right. All right. So A is correct, B is correct, and C is correct. So yes, you're gonna have to call a healthcare provider. It does have a low sodium. Your medications will need to be administered to this patient. And the reason D is incorrect, it would worsen your problem. And E is incorrect because this patient is on fluid restriction, right? Let's look at the next one. And what would you want the answer to be?
B.
B,
D.
D.
D, oh, I see what happened. I don't really have a D, huh? All right. So let's see. All right. So the patient is actually in fluid volume overload, which could be worsened with the sodium. So the 3% may need to be adjusted because it's causing some complications. Your sodium level is normal. If anybody wanted to say A, I can somewhat understand that. Because maybe you're thinking they're getting a little too high, but I think they allow a certain range to be a little bit more over the 145 in this situation. Your potassium, that was okay. And C, the problem was beginning to resolve. Okay. All right, this is a DI question. The best answer?
B.
C.
C.
Okay, B and C. All right. Can you give me your rationales?
If they're losing fluids, you want to replace it.
You want to replace the fluids. All right. And someone said B. All right. Why did you say B? It's not a bad thing.
Well,
but they usually have orders. Yes.
Yeah.
They usually have orders, so B might have been an unfair option. C is correct. The patient needs the fluid replacement. You remember we talked about fluid replacement, like if the hour before they put out 700, then you need to get 700 back in them. Sometimes if it's a copious amount, like even 700 is kind of difficult for some people to drink. So sometimes you need to use like a hypotonic solution, like half normal saline. If the replacement was 500, maybe people can drink 500 milliliters. 700, maybe they can, maybe they can't. I don't know. So this patient is hemoconcentrated. And the reason B would be incorrect is because healthcare provider has diagnosed this patient and would expect the urine to be a little elevated.
And Ms. John, I have to assume they had an order already, huh?
Yes.
Yeah, see, that's what I did.
On this level, I know they said assume. Yeah. So you're correct. Thank you. Thank you for responding. All right. Anyone wants to answer?
D.
Is she correct, guys?
Yes.
Okay. All right. Let's see. So that would be correct. A is incorrect. The fluid of choice in how much you would give. Let me see. I need to go back to the question. All right.
That's not the same question.
That's the next question, right? So it went down. That's where I want to be. The mother said, I don't know how I came up with that answer, but okay. So it's 350. All right. Corrective respiratory acidosis is given amplified card. Not sure why I said that. But anyway, D is the correct answer. All right, this is, I think, the last question. I think everybody
B.
would get this one.
B.
B.
Yeah. B as in boy. Yep. Anybody else has a difference in opinion? I think this is the last one. All right. Let's see what happened in the chat box. All right. Yeah, because I can't follow the chat box as I'm moving on, but I see glucose, but I don't know which question was answering at the time. Okay, the steroids. Okay. Thank you, V. All right. Do you all have any questions? I'll be here a few minutes if anybody has questions. If not, thank you for attending, and I'll see you all later.
Ms. John, I have a question.
Okay.
So I was watching like a video on YouTube, and one of the videos was talking about possibly giving a patient like D5 with insulin so that their blood sugar levels wouldn't drop too quickly. Does that sound like anything you've ever heard before?
Yes, I've heard it before. That's usually not practiced in a critical situation.
Okay.
I think that was Pearson, right? That was the Pearson.
It was Nurse Sarah.